Hi everyone, welcome back to the third video of this week lecture. So for this video, we're gonna discuss on the second generation antipsychotic agents or known as atypical antipsychotics. So the second generation or atypical antipsychotic drugs can be differentiated from traditional antipsychotics by their low or negligible levels of these unwanted side effects. So this drug considered atypical because they have a lower incidence of extrapyramidal symptoms, tardive dyskinesia and hyperprolactinemia, yet are equally effective as typical antipsychotics in reducing the positive symptom of schizophrenia. Not only that, it's more effective at reducing the negative symptom of schizophrenia compared to the typical antipsychotic drug. Although in general, it is supposedly associated with increased safety, that is not entirely true as they have been linked to the metabolic syndrome. So the primary distinction between the classical and second generation antipsychotic have been made on the clinical basis. The second generation of antipsychotics, or known as atypical antipsychotic drugs, also has the ability to block the dopamine receptors. So it means that this typical as well as atypical has the ability as the D2 receptors antagonist. Not only that, atypical is differs from the typical because it shows serotonin binding ability. Besides that, the binding of these atypical drugs to the dopamine receptors is quite loosely compared to the typical antipsychotic drugs. So it means that this atypical can be loosely bound, which will cause the dissociation constant higher than the typical antipsychotic drugs. And it also differs in terms of the side effects. From a pharmacological perspective, the current atypical antipsychotics, also known as serotonin dopamine antagonists, as you can see in this picture or in this figure, beside this drug has the dopamine D2 receptor antagonist, is also present in serotonin 5-HT2A receptor antagonisms. So in these additional serotonin antagonisms that mediates this atypical antipsychotic clinical profile of low extrapyramidal symptoms as well as less hyperprolactinemia with comparable to the antipsychotic agents. Each of these mechanisms will be discussed in the next few minutes. The first of theory of atypical antipsychotic action is that these atypical drugs have lower affinities for the dopamine D2 receptors and loosely bound and rapidly released from this receptor. As you can see in this picture, the blue color one here represent the atypical antipsychotic or known as second generation antipsychotic, which bind more loosely to D2 receptors compared to traditional typical antipsychotic, which is the yellow color one, bind more tightly to these receptors. So the drugs such as quetiapine, clozapine, ramipride are quickly dissociated and took less than few minutes to release it from the receptors compared to the traditional antipsychotics such as haloperidol, chlorpromazine, which were displaced much more slowly from the dopamine D2 receptors. So the second generation of antipsychotics, or known as atypical antipsychosis, much better compared to the first generation antipsychotics. It because this drug, as I mentioned earlier, has the serotonin antagonist effect, which this serotonin antagonism does not interfere with antipsychotic action in the mesolimbic pathway. So we can say that the potency of these drugs to reduce the positive symptom are equivalent to the first generation antipsychotic drug. Not only that, the serotonin is you need to know that in the negative pathway, The serotonin itself will inhibit the dopamine neurotransmission in the mesocortical pathway, which we can say that this serotonin acts as a brake on dopamine. So the atypical antipsychotic, which has the serotonin antagonist, will release the brakes. So it will enhance the dopamine release, thereby alleviate these negative symptoms. Besides that, unlike with the first generation antipsychotic medication, this second generation antipsychotic have a significantly diminished risk of extrapyramidal syndrome at a recommended dose, and it also can reduce the risk of causing tardive dyskinesia. It's because these drugs are rapidly dissociation from the receptor itself. Not only that, the serotonin antagonism in the tuberous inflammatory pathway will decrease the hyperprolactinemia. So the serotonin antagonism in the negotiator pathway theoretically will reduce the extrapyramidal symptoms as well as the tardive dyskinesia. So exactly how does this dopamine release by serotonin antagonism can be reduced the extrapyramidal symptoms? In the negostratal dopaminergic pathway, its projection from the substation nigra to the stratum, which involves the caudate and tryptamine. So normally, serotonin is the pink color one here. It reduces the dopamine release from the stratum by action of serotonin at the various serotonin 2A receptors. The typical or conventional antipsychotics, which are the D2 antagonists, will block the D2 receptor. If occupancy of this D2 receptor reach more than 80%, it will cause the extrapyramidal symptom. This is exactly what happened with conventional antipsychotics. So how atypical antipsychotic drug cause less extrapyramidal symptoms? So as you can see in this diagram, so this represent the atypical antipsychotic drugs that has two functions, which is as an antagonism in the serotonin receptors as well as in the dopamine receptors. One is bind to the serotonin receptors. It will no inhibition of dopamine release, which will cause less extrapyramidal symptoms. Not only that, this a lot of dopamine neurotransmitters in the synaptic cleft will compete with the dopamine receptor antagonism in the stratum, and which will reduce the dopamine receptor binding below 80% to more likely about 60%, which is enough to eliminate the extrapyramidal syndrome. So normally, dopamine will inhibit the prolactin release from pituitary lactotroph cell in the pituitary gland when it binds to D2 receptors. At the same time, serotonin will stimulate the prolactin release from pituitary lactotroph cells in the pituitary gland when it binds to serotonin 2A receptors. Thus, serotonin and dopamine have a reciprocal regulatory action on prolactin release. So the conventional antipsychotic drugs are D2 antagonists. Thus, it will oppose the dopamine inhibitory role on prolactin secretion from pituitary lactotroph. Thus, these drugs increase the prolactin levels and which lead to galactorrhea, amenorrhea as well as the osteoporosis. In contrast to the second generation antipsychotic, which has both antagonism effects in the dopamine as well as the serotonin receptors, so they produce a little effect on the prolactin release. So bear in mind that atypical antipsychotics are not simply serotonin dopamine antagonists. Some of the atypical antipsychotics also have very complex pharmacological properties, as you can see in this picture. So the atypical antipsychotic, which has only the serotonin and dopamine antagonists such as risperidone, ziprasidone, and saltindol. So the latest one, which is the atypical antipsychotics, has a multi-active receptors that targeted many receptors agents such as clozapine, olanzapine, and quetiapine. So these atypical antipsychotics have some of the most complex mixtures of pharmacological properties in psychopharmacology. Beyond antagonism of serotonin to A and D2 receptors, agents in this class interact with multiple other receptor subtypes for both dopamine and serotonin and have effect on other neurotransmitter systems as well. Some of these multiple pharmacological properties can contribute to the therapeutic effects of atypical antipsychotics such as antidepressants, antimania, and anxiolytic effects, whereas others can contribute to the other side effects of the sedative hypnotics and cardiometabolic effects. The side effects that result from D2 receptor antagonism are more commonly associated with typical antipsychotic drugs such as extrapyramidal symptoms, the hyperprolactinemia, and tardive dyskinesia. Meanwhile, for the atypical antipsychotic drugs can cause the metabolic syndrome-related symptoms such as diabetes, weight gain, and dyslipidemia. So it is believed to be primarily caused by the antagonism of serotonin and histamine receptors. These metabolic syndrome-related symptoms are believed to be primarily caused by antagonism of serotonin histamine as well as the muscarinic receptors. Although all antipsychotic, which is the atypical antipsychotic, shares a class warning that will cause weight gain and risk for obesity, dyslipidemia, diabetes, and accelerated cardiovascular disease, and it also can cause death, there is also actually a spectrum of risk among the various agents. Example, clozapine and olazapine is a high metabolic risk compared to the risperidone, paliperidone, quetiapine, which is the moderate metabolic risk. So to those who are consuming aripiprazole has low metabolic risk. So as you can see in this table, olazapine and clozapine produce more weight gain compared to other antipsychotic drugs or atypical antipsychotic drugs. The pharmacologic mechanism for what propels a patient taking an atypical antipsychotic along the metabolic highway of this risk are only beginning to be understood. The metabolic highway begins with increased appetite and weight gain and progress to obesity, insulin resistance, and dyslipidemia with increase in fasting triglyceride levels. Ultimately, hyperinsulinemia advanced to pancreatic beta cell failure, prediabetes, and then diabetes. Once diabetes is established, risk for cardiovascular event is further increased, as is the risk of premature death. Receptors that associated with increased weight are the H1 histamine receptors as well as the 5-HT2C serotonin receptors. So once these receptors being blocked, particularly at the same times, so patient can experience the weight gain. So the 5-HT2C receptors, when activated, it will block the feeding instinct. So when this receptor being blocked by the atypical antipsychotic drugs, in the ventromedial hypothalamus, it will cause the patients to eat more. Food intake will be suppressed by activation of H1 receptors in the ventromedial center, which is the satiety center, kenyang. So antagonism by the atypical antipsychotic will increase the food intake too. So it is difficult to predict who will have weight gain. So each drug has its unique spectrum of affinities for different receptors that resulting in significant differences in the incidence of these side effects for the drugs. As example, olazapine and clozapine have the highest affinity for these receptors, which is the 5-HT2C as well as the histamine H1 receptors. So it will cause more weight gain, while antipsychotics that produce less weight gain and diabetes such as ziprasidone and aripiprazole have a very low affinity. Since weight gain can lead to obesity and obesity to diabetes and diabetes can cause cardiac disease along the metabolic highway, it seems feasible at first that weight gain might explain all the other cardiometabolic complications associated with treatment with those atypical antipsychotics that cause the weight gain. This may be true, but only in part, and perhaps mostly for those agents that have both potent antihistamine properties and potent serotonin 2C antagonist properties, notably the clozapine, olanzapine, and quetiapine.